Okay, I think I can say welcome everybody to today's webinar. We're delighted to see actually such a great turnout today, so I hope you'll find this valuable. Earlier this year, we launched your support hub on our website, and we kicked off our webinar series with an overview of FL. So please do head to our website and take a look at that. We covered some of the basic topics like diagnosis and evaluation, initial therapy. So you can watch that at any time. In coming months, we'll have some more webinars coming up. So we hope to be able to shed some light on topics that are most interest to you, the FL community. A couple of housekeeping things from me, and then I'll pass on to the panel. Today's webinar is being recorded. So we plan to upload the final video onto our website, and only the speakers will be visible on that video, so the chat won't be visible, don't worry. Thank you to all who submitted your amazing questions. We have so many at registration, so we'll try to cover as many as we can today and save others for future webinars. You're very welcome to ask questions throughout today's session. Please use the Q&A section if you can, so that we don't miss it in the chat area. And finally, we'd love to connect with you a little bit more with the live audience here. So if you feel comfortable sharing, do leave a comment in the chat about how you're affected by FL. Are you a patient, loved one, healthcare provider, and which country or region you're joining from. So Mitch, over to you.
Thank you. So it's wonderful to see everybody, or to know that everyone's online and the response. For today, we're going to focus on outcomes stemming from the International Conference for Malignant Lymphoma held in Lugano, Switzerland back in June, and we had a satellite symposium there. And obviously we can't cover all sorts of questions, but we do appreciate the questions that have been submitted, and we will try to cover many of those in aggregate, if not specific. In the webinar today, we will have a couple of polls. We are very interested in your responses, and as well as your responses and feedback at the end of the webinar. The Q&A function is open. Again, we won't be able to get all the questions, but hopefully over the future, it'll get us in the right direction. Please be aware that we're talking about some cutting-edge advances in follicular lymphoma research today. The information and discussions today are for informational purposes only, do not constitute medical advice. So please consult with your own healthcare team for your specific medical advice. I'm sure there's a range of knowledge among the audience today. We will try to make this accessible to as many participants. But we do assume, since you're here, that you at least know a little bit about what follicular lymphoma is. We do have some basic knowledge sessions on our your support hub on our website, and you're welcome to go there to refresh or to learn about basic concepts. And also there is our overview of FL webinar from May, where we had excellent panelists talk about diagnosis, staging, initial treatment, rituximab maintenance. And I know a lot of the questions we got we won't cover today, were covered in that one. So please feel free to go and listen to that one as well. With that in the background, we're going to have a short video that's pre-recorded, and the speakers on that include Nikki Greenlee. He's the founder of the Living with Follicular Lymphoma Facebook group, which I hope many of you are participating in or will add your names to that. Nikki was diagnosed with follicular lymphoma in 2014. She commenced treatment upon her diagnosis and has so far fortunately remained without evidence of disease, otherwise known as NED. And she founded the Living with Follicular Lymphoma Facebook community the following year in 2015 after seeking support. And she's really been a driver of this and showed a great passion for patient advocacy and information. I'm pleased also to be joined on the tape and in person by Dr. Loretta Nastupil, who's the Deputy Chair and Section Chief of the Lymphoma Myeloma Section at the MD Anderson Cancer Center, renowned institution in Houston, Texas. And she is the Section Chief focused on indolent lymphoma and new drug development teams. So it fits very nicely with our themes today of designing and conducting trials aimed at exploiting the immune system to eradicate B-cell lymphoma, which makes us all excited about this. So with that in mind, you know, I would also want to mention that follicular lymphoma, very heterogeneous disease, and also geographically, what's available to you for treatment is very varied, whether you're in the United States, the UK, other parts of the world. So some of the treatments we're going to talk about today may not be accessible to you, but some may be on a clinical trial, et cetera. So what we're going to do today is talk about, as I said, the ICML conference, data coming out of that, and our symposium that made us think about thinking about that cure word, which we haven't used in a long time for follicular lymphoma. We're going to talk about some of the barriers that may be holding us back from cure. And before we open, I thought let's kick off with a poll that we'll put up on you know, what your thoughts are, whether we're close to a cure. Hopefully you'll see the poll up there. There's no right or wrong answer. We just wanted to get a sense of what people are thinking. And then as we're waiting for that and we get that in, I would ask Dr. Nastapul to perhaps maybe talk to us about what is a cure? How do you define cure? That came up in a number of questions. Functional cure, real cure, how you define that. So when the poll closes, I'll give her a moment to think about that. And then when the poll closes, we'll ask her to answer that one. Can we close the poll and see how we're doing? So pretty good mix, everyone. Some things were, you know, some are already cured, some will get there in the next 2 to 5 years, some up to 10. And, you know, about a third of people don't know, and I would have to put myself in there. We're hopeful, but we don't really know. We're hoping it'll be quickly. So, Loretta, maybe you can tell us how, you know, patients said, what does a cure mean in follicular lymphoma?
Yeah, I think from a provider perspective, we're trying to help people predict the future. And so when we discuss curative options, we're describing what is the probability of a given treatment resulting in the cancer going into remission permanently, where then you'll never have to be concerned about recurrence. But we deal with probabilities. There are no certainties. And so we use our knowledge gained over years of experience with a given therapy to project that probability that that treatment is going to result in a one-time treatment and you're done. And I think the challenge in follicular lymphoma is that most of our treatments, the probability is low that that's their last and only treatment. So then the other concept is there a functional cure? Because if I can also counsel patients that they're likely to have a normal life expectancy while living with a disease like follicular lymphoma, is that a reasonable goal? Because I think most people approach this two ways. They want to live a long time, but they also want to have a good quality of life during that long life. And so that's where we're always trying to come to some middle ground or agreement of how can we achieve those two goals.
Great, thanks. Yeah, I think that's the key. The cure is not just even one thing, and it may actually be additional things and different for each person. So let's go to the discussion, the tape that Loretta and I and Nikki did earlier as we were talking about outcomes from the Lugano meeting and our seminar, our symposium.
I just want to thank the FLF for the opportunity to be able to come on here and ask questions on behalf of all the FL patients within our community and outside of our community. So let's get started. Mitch and Loretta, where are we now on the pathway to a cure?
So we had a satellite symposium in Lugano, as you know, and we asked that exact question. And I think we came away from that very optimistic that we are on that pathway, and also clear we're not there yet. We have some really nice tools. Dr. Nastapul talked about bispecifics and CAR-T, which we'll talk about a little bit more. We had molecular testing, we had biology, putting all this together. The steps are in place, we're just not there yet, but we can see the future. Loretta, any thoughts on that one?
Yeah, I think, we're all trying to achieve a similar goal, and that's to give patients a normal life expectancy without toxicity and longer intervals in the absence of treatment. I think some of the challenges that still lay ahead of us is we don't have patient-specific approaches. We can't quite yet personalize this therapy, and we're not confident to tell people after one treatment that their disease is never going to come back, even though we know there's probably a small portion of patients that is true. So we need better tools to individualize the therapy, to do surveillance, and give us as treating clinicians confidence as to what the outcome of each treatment's going to be.
Yeah, so how do you think we can get to that point that we know that somebody is cured of the disease?
Yeah, I think we heard some interesting discussions. Jessica Okason walked us through, how does the lymphoma come back? What is our current theory or hypothesis as to why we can actually drive it into remission, but then it still reemerges? And so I think we need to know more about the mechanism as to what's driving that. Are we eradicating all of the lymphoma cells, and then a new stem cell props forward and generates a new clone? Or is it we're just driving it down to the point where we can't detect it, and these cells are kind of quiet, they're not really active until later on you get enough quantity of it emerge that we start to see it again. So we need better tools to track the tumor cell itself. We need better tools to eradicate it with our treatment. And I am excited about some of the therapies that are emerging. And we need better surveillance. We need to be able to follow patients with more confidence to know, do they have disease or not?
Yeah. So what you're saying is we need to understand the biology of the disease better. So what do you think that could mean for patients?
I think Mitch, I'll jump in, I'll hand it over to you, but I think in general, we need more people studying it. And I think that's where, you guys, the Follicular Lymphoma Foundation did a fantastic job of bringing the world expert, Ari Melnick, who knows more about this biology than anyone else. And we need to partner as a community to share our knowledge and to join forces so that we can study this, since it is a rare disease and patients and resources are limited. And Mitch, you have a ton of experience in this area, and I'm curious to hear your thoughts about that.
Sure. I think, one of the things we find is that follicular lymphoma, as an oncologist, you think, I worry more about those people with aggressive lymphoma, and the follicular patients do all right. And so even in the lab, people haven't focused as much on FL as we would like. So one of the jobs of the FLF and people like Loretta who are working in this area is to promote, to say that, we haven't fixed this disease. There's 20% of people who don't do as well as everyone else, who relapse early or transform. And even if you live a normal lifespan, you do have toxicity of treatments, the anxiety of returning. So we do need to focus more attention on it. And I think we are close to, we are getting more people involved, and we understand the biology a lot better. One of the things I came away from the Lugano meeting was the incredible increase in knowledge of how B cells develop. It's very complicated, but the more we understand that complexity, the more we'll understand follicular lymphoma biology and lead to all of the answers that we're all seeking. So it is important to understand the biology. That doesn't mean we're not making progress in treatment in terms of new immune therapies, et cetera, but to really say, are those treatments curing people? How do we use them best? That's going to require knowledge of the biology.
Yeah. Okay. So are these the barriers that are stopping us from getting to a cure? A lot of it is it timing, that, we're having to wait a long time to see if it's working? Are those a part of the barriers?
I think that's one challenge. I think the other challenge is the disease itself is heterogeneous. And again, that's something I took away from Jessica's discussion. We do sampling of one lymph node or one, bone marrow biopsy, and we make assumptions that all of the lymphoma in a given person is reflected in that one small sample. But we know that if we look at 100 patients with follicular lymphoma and give them the same treatment, we're going to have vastly different outcomes. And so I think we need to understand better, not only the heterogeneity between patients, but also within a person and the disease itself and how it behaves differently over time. So I think having improved technology that gives us a better understanding of the actual disease in a person. And so can we do it with blood tests as opposed to sampling lymph nodes in bone marrows? Can we get more information from every patient that goes on trial so we understand how the drugs work well and how they fail to achieve the goals we want? And secondly, can we use information that we just gained from the last study to inform the next clinical trial we do? And so again, I think it needs to be a global effort. We all need to collaborate, where again, with every individual patient, every trial, we're able to learn and then propel that knowledge forward for our next study.
And I would say, I'd echo the heterogeneity, especially over time. When you say, oh, my lymphoma's back, it's not really the same thing that it was 3 years ago when you first had it, because now different cells have come back after the treatment. The resistant ones have come back. They're a little different, a little harder to treat. And these molecular tests that we were just talking about, especially in blood, might, in theory, allow us to say, this is the change which made it resistant to that first treatment. So therefore, this is the best treatment right now because it's going to attack that new change. That's the dream. We're not there, but if we understood the biology, if we could get a blood test that would sort of give you the whole picture of what's going on in the whole body, there might be 10 clones of cells and we have to attack all 10. So I think we at least can define the problem, and we can see that the technology is coming to have those sorts of answers.
Yeah, okay, that sounds exciting. So if we did have a test, like a blood test for this, what do you think that would mean for the patient?
I think there's two ways you could think about it. You could look at it as being sort of a comprehensive biopsy, where it gives us clinicians information about what is unique about the tumor in front of us right now and how might we approach it differently. And then the other way you could look at it is, have we eradicated all the tumor cells in the body, as sort of a detection of how much tumor is present. And so that would be the optimal test. I think some of the limitations of the tests we've been using is just looking at quantity, and that hasn't really translated into informing treatment and how likely patients are to have been cured with a given therapy. And so I'm hopeful, again, it is early, but as we get more information about the tumor biology and then quantity, and then use that to inform, okay, how successful was our last treatment strategy and what do we need to do differently for our next treatment? That would be a major step forward.
Yeah, I would echo that. And I would add one other thing, which is one of the things that a lot of patients are concerned about, and as clinicians we're concerned about, is transformation to an aggressive lymphoma. And there are some early signs that we might be able to identify that in a blood test before it actually happens, and give us some lead time so that we don't wait for a patient to get sick and have symptoms and get a biopsy and then start treatment, but we could intervene early and maybe prevent or make that treatment more effective. So I think that's an area that would be great if we could tell you, you're safe, you're not going to transform in the next period of time, or gee, there's some concerns here, let's go in and do something sooner rather than later. So I think that's an area that I would really, be helpful. Even if we can't cure the rest of the disease, that alone would help us with a blood test. And of course, a blood test is a lot easier than going through repeated biopsies. Yeah.
Absolutely, much less invasive. And I think something like that would get a lot of us excited and feel a lot more secure. What are some of the new treatment options up and coming that you guys are most excited about?
I think I'll let Loretta take that because she talked about those at our symposium.
Yeah, I think what we can apply in terms of looking backwards over the last 2 decades, what makes the most sense in terms of targeting these tumor cells. And we know that rituximab, for instance, 20 years ago really did change things quite dramatically by using an antibody that helps your own or patient's own immune system see the lymphoma cells where they've been failing to do so. Sort of the next wave of that is applying a lot of newer technology, and 2 things that I think I'm looking forward to see this get into more patients' treatment options are bispecific antibodies, where you use that principle of targeting the lymphoma cell with just an antibody, but also the term bispecific means you're engaging your own T cells that are in circulation. And so by bringing the immune system into proximity and helping it see the lymphoma cell, that to me is exciting. And it's a new emerging therapy where we have access to it in a few countries, including mosunetuzumab in the United States. The other thing, which is a little bit more directed and a little bit more resource heavy, so there are some limitations to access, and is CAR T cell therapy, where we actually take T cells out of patients' bodies, modify them so it can actually bind and see proteins on the surface of the tumor cell,
upgrade them a little bit so that they're more prone to activate and bring in reinforcement. So these are two different strategies to help patient's own immune system see and eradicate tumor cells. And it's early days. CAR T, again, approved in a couple of countries, bispecifics in a few countries. So I hate to see the disparities emerging in terms of access to these treatments, but I do think these are particularly exciting treatments. Mitch, your thoughts?
Yeah, I agree. I think, the ability to harness your own immune system, now the T cells, but in the future, even other cells, to get those T cells to recognize the lymphoma and kill them is really that potential to get us away from chemotherapy. They're being used right now in patients who are further down the line in their treatment, but you could see them moving up earlier. You can see them in combination with other treatments. So there's many trials going on. Even if they're not approved in your country, there may be trials going on that may give you access. So I think we're very excited because it just changes. For decades, we've been giving different chemotherapies. Rituximab, as Loretta said, changed the game. That was 25 years ago. And this is really, I think, the next game changer. So early days, want to be sure that, it's not the magic for everyone, but I think it's a new tool that we have that's going to be very exciting, and we really need to keep our eyes on that and really push the field forward.
That was a really interesting discussion. Thank you so much, Mitch, and thank you, Loretta, for helping answering some of these questions. I'm sure there's going to be so many more questions burning from the other participants. So let's move on to the live discussion section.
There we go. I want to thank Nikki for that, and if she's awake in Australia, thank you for your help with that one. And so, we had a huge number of questions come in before the seminar, and as I mentioned, we're not going to really talk much about initial diagnosis and treatment because that was covered in our first one. And what strikes me in looking at the chat, and people are kind enough to put in some of their history, is the heterogeneity of this disease. And people, everything from watch and wait for years to, gee, I've had a treatment and I've had my second treatment. And it's all over the place. I see someone who was in remission for over 10 years and then came back. That happens. Some people are in remission, as in the PRIMA trial with bendamustine rituximab or RCBP and rituximab maintenance for 10 years, and that's wonderful. So it's really so heterogeneous. And it makes it hard to talk about cure. A couple of the questions that came up in the webinar were about stage 1 follicular lymphoma, which is actually quite rare, and so we don't talk about it much, but often treated with radiotherapy. And the sense is that we do cure some of those, and we use that treatment because it's pretty non-toxic. You give a low dose of radiation to the one area. And another question talked about allogeneic stem cell transplant as a cure, and that is also a potential cure of this disease, but not used very often. So, Loretta, maybe you can tell us why we don't use allotransplant, why we're excited about CAR T as maybe in that range, or autotransplant. So why don't we use allotransplant when some people are cured with that?
Yeah, recognizing that allogeneic stem cell transplant kind of gets at what the goal of our modern therapies are trying to achieve. Can we use the normal immune system to eradicate tumor cells? And for patients, their immune system is falling short. Could we replace their immune system with a more functional immune system? And that's essentially an allogeneic stem cell transplant. The challenge is with that approach, though, is that you need that immune system to not also pose risk or harm to the host. And so you have to find a donor. Generally, we look first to patients' full siblings. They've got about a 25% chance that each sibling's a match. But if you don't have an adequate match from a sibling, then we go to the national donor pool. There are challenges there, but depending on ethnicity, good chance that about 75% of Caucasians will find a donor. So step 1, do you have a donor? Step 2, do you have disease that's going to lend itself to several months of getting prepared to pursue that transplant? You got to make sure the donor's healthy. You got to make sure that the recipient or the patient is set up and is healthy enough to proceed. So there are a lot of just barriers and challenges. Once we actually successfully infuse those stem cells, then we're watching closely at first to make sure that they can actually migrate back to the bone marrow, set up shop, and start making those important bone marrow cells like white blood cells, hemoglobin, red blood cells that we measure in the form of hemoglobin and hematocrit, and then platelets. And so the first short period of time, we're supporting patients through potential risk of infection because they don't have good bone marrow function. Once the bone marrow is set up shop and is ready to perform its duty of eradicating tumor cells, then we also need to keep it in check so that it doesn't put patients at risk for graft versus host disease. So about 10 to 30% of patients will have really severe complications of transplant in those first few weeks. And then there's about 30% that might have chronic graft versus host disease. And so those are just the numbers for the patients who have an adequate donor. So I highlight that to illustrate why it's infrequently done, but yes, can absolutely cure follicular lymphoma.
And as you mentioned, so that's a proof of principle, but very difficult. And I think that's why we're so excited about these other immune therapies, such as CAR T, that we hope will give us those sorts of outcomes without all the toxicity, although clearly there's toxicity and they are not without their accessibility issues as well. What do you think? I don't want to put words in your mouth about CAR T versus bispecific antibodies, because that's it may, I'm not sure we want to go there because it's not accessible to everyone and we don't have the answer. But what are your thoughts? Are we curing anyone today with either one or the other of these mechanisms?
It's too early to say yes, though there are some clues that we should be optimistic about these treatments. And it gets back to the challenge with follicular lymphoma and studying new therapies. Most patients do really well. And if you hear anything from me today, as frustrating as it is to have this disease, and not everyone's going to have similar or good outcomes, there are a good portion of patients that do really well. So we have to follow patients for decades to really see the impact of a treatment on the natural history of the disease. And so these newer therapies they're too new to really understand what is their major impact on people's lives. But why I'm optimistic, if we look at the percentage of patients going into a complete remission and the percentage of patients staying in a complete remission beyond 12 months, it looks much better than what we were achieving previously with therapies, particularly chemotherapy, and maybe to even some extent lenalidomide, which is an oral drug that can also modulate immune cells. And so for that reason, I'm optimistic that we might be seeing a shift in how well people do. We just need to follow them for the next 10 to 15 years to have more confidence that that is going to hold up.
Yeah, I think that's exactly, I would agree with that. And that gets to the second question, which we talked about a little bit on the video, and there've been some questions about that, is about blood tests to monitor. And, I think, it's aspirational. It doesn't exist at the moment because, we really don't want to wait 10 or 15 years to say, oh, you were cured or you weren't. We'd like to know now, at least who's likely to be. So there is a question answered today, like, I mentioned in the video, a future transformation blood test. I want to stress that doesn't exist today. There's signs that we might be moving in that direction, but those sorts of blood tests do not exist today. And there's another question about genetic testing or testing, not so much in the blood, but of the lymphoma to see who's likely to do better or worse. So I don't know if you want to comment on what the status. I know we don't have any great biomarkers for who's going to be in the less good group and who's in the better group, but any thoughts on where we are with that and where we might be going?
Yeah, several different groups are really trying to identify, are there specific genes or biomarkers, as you mentioned, that can help us navigate the expanding treatment landscape? Meaning, if you have this mutation, then this is the preferred treatment option. Probably the closest thing, and again, just an illustration of progress that has been made for patients who have an EZH2 mutation, which is about 10 to 20% of patients with follicular lymphoma. We know that the oral drug, which is a pill, tazemetostat, you'll have a much better response if you have the EZH2 mutation and a little bit longer remission duration, though not dramatically so. So it's not a perfect example, but is an example where you could do a mutation panel if you have the EZH2 mutation, that might give you clues that a drug like tazemetostat might be a reasonable option in later lines of treatment. And some clues even for patients who got chemoimmunotherapy, so chemo plus CD20 antibodies such as rituximab or obinutuzumab, as their first treatment, that EZH2 mutation status may confer better prognosis. So we're getting there. And the more we learn about the tumor biology, the better things we'll have in the future, such as genes or mutations that give us clues as to preferred treatment.
Yeah, so I think that is a goal that we're all would be excited about achieving. There is, for instance, the Follicular Lymphoma International Prognostic Index, or FLIPI, and then there was a generation of that called M7, because there were 7 RNA expression genes, and a couple of those were epigenetics. And so we know now epigenetics plays a key role, as you mentioned, tazemetostat, but it's not the only answer. So we're getting there, I agree. But most of us don't use M7 FLIPI routinely in deciding what patients to treat. We might use EZH2 mutation third line for tazemetostat. Again, that's not available in all countries, and so some of you may not have that. But it wasn't the magic pill. It's good. It's well tolerated. Might be good in combination with other agents, and I think that's where we have to be thinking. One area that because we don't have long follow-up on CAR T and bispecifics, you mentioned before the long-term, short and long-term effects of allotransplant. We all are worried about long and short-term effects of chemotherapy. What do we know about any longer-term effects of bispecific antibody or CAR T therapies? Obviously, no one's been out that long, although someone in the pre did mention, I think they were almost a decade, like 9 years out. So they must have been one of the earliest patients with FL treated. But do we know about what the long-term effects of your anti-CD19 CAR would be, or your bispecifics?
We don't have long-term outcomes. Of the trials that led to approval, we have 3 plus years that has been reported. We'll probably see 4 years of follow-up coming soon. But essentially, if you think about how the drugs work, so they're aimed at eradicating cells that have either CD19 or CD20 on the surface. So those are proteins that are present on follicular lymphoma cells, but also mature B cells. And so if the treatment works as expected, you're going to be getting rid of follicular lymphoma cells, but also mature B cells. And so what's the downside of removing mature B cells? Well, mature B cells progress on to become plasma cells that make antibodies. And so if you think about how our immune system functions normally, particularly if it's mounting a response to an infection like a virus, you activate those B cells, they become plasma cells, they generate antibodies. Those antibodies stick to the surface of that infection, and it helps other immune cells see and eradicate that infection. And so if you're missing those B cells because you've removed them with these therapies, infections is probably the one thing I worry the most about, and particularly as it pertains to viral infections. Now, there are strategies that can be used, such as replacing antibody levels in the form of IVIG, vaccinations. Even though the B cell quantity is low, we know that you can actually train T cells, and you'll still have some memory cells potentially available to mount a response to an infection as patients get exposed. So not as well as someone who has adequate number of B cells is still helpful to vaccinate patients. And then just educating patients and caregivers that we're always on the lookout for infection.
Great, thanks. Yeah, I think, as you mentioned, even long-term rituximab has the B cell depletion, and so we are always concerned about that. I'd like to move to, after that discussion, the next poll question. What's important to you, if we can put that up? Is it more important to be cured at the cost of higher toxicity, or would it be better to have as few treatments as possible to avoid toxicities that accumulate over time? Or is it having access to more of these newer treatments through clinical trials, even if they're not yet approved? So what's most important to you? We'll put that up and see what people think. Because again, one of the things with follicular lymphoma is always balancing the benefits of treatment with the toxicities. And so when we get an oral, relatively non-toxic treatment like tazemetostat, we're excited. Transplant, much more of a commitment. CAR T, bispecifics, intermediate. So we do wonder about those things. So can we see the results of that one and see what people thought? So again, it's an interesting mix, but a third of patients are very interested in being cured, and other people are more interested in toxicities. Again, it's not an all or none. There's always a balance between those. And yeah, and a lot of people are interested in getting newer treatments, as you would expect. Loretta, when you talk to patients, is this what you see and they're balancing when you talk about the risks and benefits of alternative treatment options, and one's oral and one has this side effect and others? How do you approach that with the patient? Is it sort of shared decision? Do you sort of recommend what's going to happen?
Yeah, I think, every person comes into this at a different time point, whether it's their first diagnosed or they've got 10, 15 years of experience and have gone through a number of treatments. So each conversation's a little bit different. I don't pretend to think that there's one approach that works for everyone. But what I will highlight is just what you're seeing here. There are different goals. And I think we as providers need to do a better job of understanding what is the goal for the patient, because we're always very much focused on getting people into remission, and we want to do that with as little toxicity as possible. But sometimes I don't know that we do a good enough job describing what are the limitations of therapy. Why might we pursue one option over another when we've got a laundry list of things that we could pursue? And so it's really just balancing out what is the goal of the patient and then what do we think we can achieve with treatment. And the most common question I get from patients is, why does this come back? Even if we have a lot of confidence that we can put people into remission, we also have pretty high confidence at some point it's going to come back. That seems counterintuitive. And so how can we do a better job as a community of addressing that question that I face the most?
Thank you. So that leads us actually into the third poll question we're going to have. And I should preface this by saying that, CAR T and bispecifics right now in the United States, at least, are approved as third line or later. So after 2 prior treatments, people are thinking, and there are already studies looking at CAR T second line in the high risk patients, and bispecifics even up front. So I'm trying to get a sense of what people would think about trying new treatments. Would you be willing to try CAR T, bispecifics, anything your doctor recommended? Only later after you've had the more standard treatments. So when we say a new or experimental treatment, or one that hasn't had long follow-up, we'd sort of be interested in your thoughts on that. And while you're doing that, I'm just going to comment that, of course, time flies in these, and we only have about 5 minutes left after this, so we'll discuss this, and then maybe I'll mention a couple of other points as I put together some of the issues. And again, I do want to stress that a lot of the questions about scanning and follow-up we did discuss in the first webinar, which I encourage you to watch. All right, let's see the answer to that. Again, a mix. So I think it's encouraging. Sometimes, at least in the United States, the patient-doctor relationship has changed over the years. So it's encouraging that almost 2/3 of patients are willing to listen to what the doctor would discuss and recommend. And everyone's, I think there's definitely an excitement about CAR T and bispecifics should you need them. And I think fewer people would want to stay with the standard treatments. And there's nothing wrong with that, especially if you're doing well with them. If you've gone 10 years after first line treatment, there probably wouldn't be a need to start thinking about experimental treatments that we don't have long-term follow-up. So again, as Loretta said, it's one size does not fit all, and you really have to tailor the risk benefit to how your disease is behaving. So go ahead.
I may interrupt you just for a second because I see a comment, and I think it's the most important comment, probably particularly for this audience, is as a patient and being an advocate, how do they help advance research for follicular lymphoma? And that's, I think, so critical. And one of the easiest things to do is just ask your doctor, is there any research I could participate in? Because sometimes we also, as providers, have unperceived biases that people may not want to be a guinea pig, or people may not, if they express that they're not interested in trying something new, then that means they're not interested in participating in any research. And there's so many different types of research beyond just participating in a early phase clinical trial. And because this is a rare tumor type, I think every single patient, if we can learn from that experience, that's probably the best way to move the field forward. And that's why I love participating with the Follicular Lymphoma Foundation and engaging with you, Mitch, is how can we come together as a group to really learn and move things quicker?
I couldn't agree more. And there's the idea that as many people as possible should go on clinical trials, because that gets them done sooner and we get the follow-up and we get the answer. And, you know, you mentioned being a guinea pig, but most clinical trials are really not at that stage. And there are, and I know at MD Anderson, you guys specialize in those sorts of things and we appreciate that. But there are many trials out there comparing, say, CAR T and bispecific or something where you're going to get an active treatment. So it's very important to listen to what the research is and decide about how you feel about it. The other thing I wanted to mention is, you know, the biology, as we talked about, is really important. And samples, either from your tissue or blood, are critical to allow the doctors in the laboratory to study and understand the biology. So even if you're willing to donate tissue to a center, and the FLF, we have plans underway for ways to help facilitate that. And we may be reaching out to people in the future about your data, and it's the samples, it's your clinical data. Again, the heterogeneity is such that we really need large numbers of patient data treated with different things, and the data and the clinical data and the biological data is critical to making headway. So we really appreciate that question, and we appreciate what Loretta does in her work and what the FLF is working towards to help and provide ways in which patients can help themselves as well as the rest of the FL community. So we're very excited about that. There is a link in the chat now to the first webinar, which you can watch at your leisure. So I think it's almost time to close. So I am going to say this is a very heterogeneous disease, as you can see in the chat. One size does not fit all. Dr. Melnick at our symposium, said there's many flavors of follicular lymphoma. There won't be one cure. There'll be one cure for people with this type of follicular lymphoma. Another might be another one. Lenalidomide work better for one patient, CAR T for another, et cetera. So I think we need to keep our options open. And it is important, as I mentioned, of collecting large-scale data and collecting tissues for accelerating the pathway to a cure. Having both the clinical data and the samples from a broad range of patients is really a key to unlocking this. We think this is actually important. So we are focused on FL at the FLF, and we appreciate everyone's interest. We continue to engage with top experts like Dr. Nastapul, Dr. Hill, and Dr. Okosin on our original webinar, and the people in our symposium. And we are really interested all the time in our patients and what they have to say. There will be a review, a feedback form at the end, which we would really appreciate, and ask you what topics you want to hear. We do have a webinar series planned, and we will have a series of some that are more focused on different treatments. So I want to thank obviously all of the audience for attending and sharing their stories, Dr. Nastapul and Nikki Greenlee for their assistance. As I said, future webinars will delve more deeply into some of these. Also look out for the FLF on social media for updates on the webinar and other announcements that are coming. And again, we really appreciate your feedback. So we are all of 1 minute over, but I want to thank everybody today. We thank you, and we appreciate your interest. We hope you find this helpful. If not, or if you have ideas that we can improve this or certain topics, please feel free and to express that. We really appreciate patient input. And with that, I want to thank you all, and hope you have a nice day or evening wherever you are. Thank you.
Thank you.